Okay, chapter 20, Neoplasms and Cancer. So what we're going to be looking at is we will be comparing and contrasting the difference between benign and malignant tumors. We'll talk about some of the warning signs of cancer. We'll also discuss the local and systemic effects of cancer. We'll describe the spread of malignant tumors and how that takes place. We'll discuss the stages involved in carcinogenesis. And then we'll talk a little bit about some of the treatments of cancer. So, neoplasms are also tumors, and it's cellular growth that no longer responds to the normal genetic control. Doesn't follow the rules. These cells continue to reproduce without the need for them to reproduce. Okay, it's just uncontrolled. There's no check mechanism. It deprives other cells of nutrition, and that becomes a problem. Now, these neoplasms may consist of atypical or immature cells. The characteristics of each tumor are going to depend on the type of cell from which the tumor arises and the unique structure and the growth pattern. So how do we name these? Let's look at the nomenclature. So there's really two parts to naming a tumor. We have to look at the root word, and then we look at the suffix. Okay, now the root word is the tissue of origin. So just a few examples. Osteo, when you see osteo as the root word, think of osteology, you think of bone. Chondro, think back to anatomy and physiology, chondrocytes. Costochondritis, right? This is cartilage. Adeno. Adeno is from glands, like the adenoids, right? Adeno refers to glands. It's a specialized type of epithelium. Lipo. Think of the term liposuction. Lipids, fats, okay? Now the suffix for benign tumors, we're going to use the word oma alone, okay? Oma. When we're talking about malignant tumors, we're going to use the word sarcoma. So let's go back here. Benign, we're going to use the word oma. So osteoma, that's a benign tumor of the bone. Chondroma, that's a benign tumor of the cartilage. Adenoma, a benign tumor of the glands. Lipoma, a benign tumor of, or like a fatty cyst. I just picked one of these up the other day in my office. Pretty common. Patients get a little bit concerned when they see this nodular cyst-like structure, sometimes along the neck or at the upper trapezius or in the upper back. So, it's important to put patients at ease. But, differential is really important, differential diagnosis to ensure that it's nothing serious. Okay, we're going to continue on the nomenclature and look at, we talked about benign tumors. Now, what about malignant tumors? So the use carcinoma, right? Carcinoma is derived from epithelium. So if we use the word, let's say, adenocarcinoma. Oh, you know what? I think I jumped on that last slide. So let's go back here for a second. So when you see the word oma, it's benign, okay? And when you see the word carcinoma or sarcoma, these are both malignant, okay? The difference is where the malignancy spreads to. So when it spreads to connective tissue, it's sarcoma. When it spreads to epithelium, then we use the suffix carcinoma. Okay, so let's look at the malignant tumors again. So we're going to use the suffix carcinoma at the end of the word if the malignancy is derived from epithelium. So when we see adeno, carcinoma. This is a malignancy of the glands, right? Think of the word carcinogenic, cancer causing. All right, we're going to use the sarcoma when it's derived from connective tissue. So osteosarcoma, chondrosarcoma, liposarcoma, right? We just upped the ante from osteoma, chondroma, lipoma, and adenoma to osteosarcoma, chondrosarcoma, liposarcoma. We've gone from benign to malignancy. So it's important to know that when you see carcinoma, it's associated with epithelium. When you see sarcoma, connective tissue. And again, malignancy. There are other malignant tumors that have names that really don't correlate to necessarily epithelium or connective tissue. They're kind of named after the physicians. So there's Hodgkin's disease. I believe it's named after, I think his name was Tom Hodgkins. And then there's Wilms tumor. I think his name was Max Wilms. This involves the kidney. Hodgkin's involves the spleen and the lymph nodes. And then leukemia, obviously, the white blood cells. So what are the characteristics of benign and malignant tumors? So benign tumors, they're usually differentiated cells that reproduce at a higher rate than normal. They're encapsulated. In terms of tissue damage, really there's not too much tissue damage. When you look at malignant tumors, these are undifferentiated. They're non-functional cells, okay? Non-functional. They rapidly reproduce. The problem with the malignant tumors is that they can infiltrate or spread into surrounding tissues. And they can spread to distant sites. When they spread to a distal or more distant site, we call that metastasis. Or they will say the cancer metastasized, meaning it started in one place and then it moved someplace else. Okay? So here, if we look at, on the left-hand side, we're looking at a benign tumor. On the right-hand side, the malignant tumor. We have a slowly expanding mass on the left side. We have relatively normally shaped cells here. We can see that it's encapsulated. Compared to the right side, we can see the malignancy. We have these abnormally size and shaped cells. They're very irregular. We have a little bit of necrosis here. We have some blood vessels that are invading. It's invading the tissue. So just on visual observation, you would see this looks contained. This looks a little bit dangerous. Okay. Let's look at side-by-side comparison here, right? So if we look at benign tumors to malignant tumors, let's look at the cells. So the benign tumor is similar to normal cell, whereas malignancy, they vary in size, in their shape and nuclei. Benign are differentiated, whereas malignant tumors undifferentiated. Benign, mitosis is fairly normal, and in the malignancy, the mitosis is increased and atypical. Let's look at the growth. Benign tumors, they grow relatively slow, where malignancy can grow rapidly. The benign tumors have an expanding mass. The malignancy, the cells are not adhesive, right? They don't stick to each other. They can separate and metastasize and move to other places. And they bounce into other cells and, convert them into cancer cells. The benign tumor is encapsulated, whereas the malignancy is not. With benign tumors, in terms of spreading, the benign tumor remains localized. Sometimes they'll say in situ, which means it's in one specific site. The malignant tumor can invade the nearby tissues or metastasize to distant sites through blood and through lymph vessels. The systemic effects, there are rarely any systemic effects for benign tumors, but on the malignant side, there are systemic effects. In terms of the benign tumors being life-threatening, only in certain locations, such as the brain. With the malignancy, yes, there is life-threatening by the tissue destruction and by the spreading of the tumors. Let's look at the pathophysiology of malignant tumors. So as the cancer grows, the cells become more primitive, right? Dysplasia, we'll see dysplasia, and anaplasia. Normal organization, growth inhibition, contact controls, and cell-to-cell communication stop. Okay. There's an expanding mass that can compress the blood vessels, and whenever you have mass that enlarges and expands and starts to impede or block blood vessels, wherever that blood vessel is going to go is going to die. And that's necrosis or necrotic tissue. It's going to lead to necrosis and inflammation all around the tumor. Now remember, tumor cells may secrete enzymes, and those enzymes can break down cells, cell walls, and other tissues, and they can break down proteins. And proteins are very, very important. It's the building block of the human body. Systemic effects, such as altered calcium levels, tumor cells stop adhering to each other, and they can also infiltrate to the adjacent tissues. And when they move, remember that's that word, metastasis. So still with the pathophysiology, we have inflammation and loss of normal cells. It's going to lead to the progressive reduction in organ integrity. And when you lose the structure and integrity of an organ, you're going to lose function. Structure determines function. Angiogenesis, when you see the word angio, like an angiogram or angioplasty, you're thinking blood vessels and blood. Genesis is the production. So there are some tumor cells that secrete growth factors that will stimulate the development of new capillaries in the tumor. So which means that if that's the case, then they're going to want to, as a form of treatment perhaps, create anti-angiogenesis factor, or just cut the blood supply to some of these tumors so that they're not being nourished anymore. They become malnourished and then they die off. What are some of the warning signs of cancer? There's unusual bleeding or discharge from a certain part of the body. There's a change in bowel or bladder habits. There could be prolonged diarrhea or discomfort. In terms of bowel habits, if there's like colon cancer, typically a lot of the cancers around the colon, they're like these tumors that grow on the outside, like wrapping around and compress. They squeeze in on the colon, on the large intestine. And when that happens, the stool has a tough time squeezing through there. And instead of having healthy stools, it's referred to as pencil-like or pencil-thin stools. That is one of the classical indicators of colon cancer, is asking about the stool, its size and shape. But when they say, yeah, they've noticed that when they go to the bathroom and they eliminate, they notice that the stool is pencil thin. Okay. There could be a change in the wart color or the wart size or its shape. Another indicator is if there is some lesion or a sore that doesn't heal, whether it's on the skin, whether it's in the mouth, anywhere on the body. Also, unexplained weight loss. It's typically 15 pounds in 2 weeks or 30 pounds in the month. Someone says, hey, Mr. Smith, you look great. Looks like you've lost some weight. Oh, I have, and I haven't even been trying to. That's usually one of the indicators. It's unexplained weight loss. Another indicator is anemia or low hemoglobin. And when there's decreased hemoglobin, then there's the decreased ability for iron to attach. And without iron, there's going to be less energy. So there's fatigue that's associated with that. There's persistent cough or hoarseness of the throat without any explanation. Also, a solid lump or palpable lump that's usually painless, right? And that's part of the issue, is that when people have cancer or they have a lesion or a bump or a lump and they go, doesn't hurt, I guess it's okay. It's the painless ones that you have to be concerned about. I just had a patient that came in the other day, and when I was examining her, she hadn't been in probably, I don't know, 7 or 8 months. And she said, oh, I'm coming in for the same condition as last time, which was a neck spasm and neck pain and headache. And I said, okay, it's been a while. You have to come in. We're going to have to examine you. Oh, why do I have to go for another exam? I just want to go in for the treatment. It's the same thing as last time. And I never treat anyone without a thorough exam. And when she came in, I'd asked her to lower her mask so I could look into her mouth. I wanted to look at her gums, look at her teeth, look at her tongue. And when she said, I noticed that the tonsils looked a little bit unusual. And she said it's been that way for about a year. And when I palpated her neck, which means feeling the neck along the side, I felt a little bit of a nodule, which could be a lymph node. And she said it's been like that for a little while. But she thought it was a lipoma because she was diagnosed with a lipoma on the back of her neck. So in any manner, this literally just happened the other day. So we sent her to her physician, sent the appropriate documentation with my notes to have him further evaluate with some diagnostic imaging as a good differential to see what that is. Could it be a lipoma? Possibly. Could it be some sort of disease of her lymph nodes? Could very well be. Okay, so it's good to work with integrative physicians and have a good healthcare team, and everyone communicates for the patient's best interest. So, and it was also painless. It didn't hurt her, so she didn't think it was anything big. So if there's a lump and it's painless, whether it's in the breast or it's in the testes or anywhere in the body, it's very important to get it evaluated. What are some of the local effects of tumors? Some of them can be painful. And sometimes pain is absent in the early stages, but at the very, very late stages, it becomes painful. And this is why early detection is so important, because these patients say, oh, had I known, this lump was there for 3 years and it just never bothered me, so I never did anything. And then at the 4th year, it becomes sensitive, and at that point, it could be in its advanced stages. So, I can't stress enough to get things evaluated early on. What are some of the other effects of tumors? Obstruction. Things can compress certain ductwork in the body or certain passageways through the body. The blood supply or lymphatic flow may be restricted. The digestive tract can be obstructed. Even tumors around the trachea or the bronchi can impede oxygenation. Tissue necrosis and ulceration can take place. It can lead to bleeding or infection in areas around the tumor. So here, this is just a tumor on the left-hand side. Looks like it's blocking. Here's the trachea, so that's the primary bronchi. Then you have secondary bronchi and tertiary bronchi. So anyway, it looks like it's blocking the right primary bronchus. Here you have an external mass putting pressure on the transverse colon. This looks like a polypoid tumor of the ascending, almost at that right hepatic flexure. And then here on the descending, here is a circumferential tumor. So this is the type of tumor that I was explaining before. If you have bowel that's moving out here, and by the time it squeezes through here, it comes out pencil thin. Okay. Systemic effects of malignant tumors, weight loss. We call weight loss cachexia. That is severe tissue wasting. Anorexia, fatigue, pain, stress, increased demands on the body from tumor cells. Weight loss is one of the systemic effects. You could just see sometimes when you, if you haven't seen someone and you heard that they're ill or they're dealing with cancer, you can look at their face and they have sometimes this sunken in appearance around the cheeks, and you could see the zygomatic bones pretty clearly. Their body starts to almost digest their own body proteins at this point. If they're malnourished and they're not eating, the body's still looking for fuel. It needs energy. So if you're not consuming fat and you're not consuming carbohydrates, then the body's going to use its own self, its own organs, its own muscle mass, which is composed of protein, for fuel. And it's unfortunate, but it's just what happens sometimes. Anemia. This is caused by blood loss, right, at the area of the tumor site. There could be nutritional deficits that reduce the body's ability to produce hemoglobin. Remember, you look at heme, which has iron and non-iron components, and globin is a globular protein. So if there's protein synthesis issues or consumption issues through the diet, the body may not be able to synthesize hemoglobin. It can also happen from not consuming enough iron or B12 for anemia. Severe fatigue, that could be caused by the inflammatory changes, it could be caused by the cachexia, and it can also be caused by the anemia. Severe fatigue, just the stress that's associated with the treatment. It could be exhausting for people. And there are a lot of psychological factors involved and stress that's involved that can create fatigue. Effusions, this is where people can have inflammation that causes fluid buildup in the body cavities, whether it is around the lungs, right? You have the pleural cavity, whether it's around the gut, the peritoneum. Infections. This occurs as the person's resistance starts to decline. And here we have bleeding again, which is associated with anemia, right? Tumor cells may erode the blood vessels. And then there's something called the paraneoplastic syndrome. This is associated with certain tumors. Tumor cells can release substances that affect neurological function, and they may have hormonal effects. There are some lung tumors that can push out PTH, right, parathyroid hormone, and that's going to raise calcium levels by breaking down bone. So when you have people who have brittle bones or the bones just keep fracturing and they don't know where it's coming from, then they have to consider cancer. There are some diagnostic tests that are very important. Just having routine screening, that early detection, I can't stress it enough. The early detection is so very important. Self-exam, whether it's breast, testicular, and skin exams are very important. Routine blood tests to monitor um, what the levels of the red blood cells are and white blood cells. These are done in just, every routine blood test that I've ever done always checks erythrocytes and white blood cell count. And then if you're suspicious, then we can always do specific tumor markers. Um, I had a patient not too long ago who had lower back pain. And it's really important and to understand, and we went through this when we did dermatomes and we talked about referral of pain, how organs can refer pain to different places. Um, the prostate in men can refer and create lower back pain. So it's something to consider for men, a very common condition of lower back pain, right? It's probably the number one thing that walks into a doctor of chiropractic to their office is going to be lower back pain. So it has to be ruled out. So this gentleman came in with lower back pain. Hey, Dr. Lindner, I've heard so many great things. I was referred to you by so-and-so. They say you're magic. Um, and, very kind. A lot of people would say that. And anyway, I was interested in helping him and I wanted to treat him. And when I started looking at his paperwork and doing my exam, I noticed that he had a history of cancer. And you really have to look through the paperwork clearly. And sometimes patients aren't thorough enough. So if there's any missing gaps, you have to be thorough and ask and investigate. So I said, oh, it says here that you've had cancer in the past. Oh, yes, I have. I said, what type of cancer did you have? He said, oh, I had prostate cancer, but I've been treated for that. It's all better. And I said, that's great to hear. It really is. I'm happy to hear that you're fully recovered. When were you diagnosed and when were you treated? He said, oh, the last treatment was about 6 months ago. What kind of treatment did you have? Oh, they put these radiation seeds into my prostate. Okay. And did you go back for your follow-up? No. You didn't go back for your follow-up? No, I hadn't been in there since the treatment. So I said, doesn't it sound reasonable that if you put the radiation seeds in there, and that was done 6 months ago, that there should be a follow-up to that you should go back and you would want to determine, hey, number one, did it work? Did the size of the prostate shrink? Did it stay the same? Or did it get worse? Because there are chances that this can become invasive and it can spread to the lower back, to the bone. So I said, we are not going to treat today. And, oh, please, doc, I heard all I need is this type of treatment. I know I'll be out of the way and I'll be better. I said, listen, based on my exam, based on my 25 years of experience and my instinct, I just have a feeling that you need to go back and get this evaluated. And it was about 3-4 days later, I had sent him a text message. Hey, Mr. So-and-so, it's Dr. Lindner, just checking in. Did you go for the follow-up? No, I didn't, but I promise I will. Let's say 2 weeks go by. Mr. So-and-so, it's Dr. Lindner, just checking in. I'd like to get a follow-up. How did the visit go? Oh, I have the visit set up. The appointment is set up for 3 weeks from today. Great. I marked it on my calendar. 3 weeks later, he goes for the exam. I give it another 7 to 10 days for any type of results to come back. So a month later, I reach out to him. Mr. So-and-so, it's Dr. Lindner, just checking in. And he said, Dr. Lindner, I can't thank you enough. He said, had you not detected this, sensed it, advised me, they said I would be dead. It did metastasize. It started to spread into the bone. It started to migrate to other places. And now he has to go for radiation and chemotherapy. So um, the other test that I had sent him for was the PSA test. That was the one thing that I ran, and that came back high. So I already knew that something was going on with the prostate. I just didn't have any of his prior test results as the baseline to compare. So I had sent them to the patient and forwarded them to his doctor, and that was it. So thank goodness, he's alive today. He was treated, and now he's in remission. But things could have really taken a turn for the bad for everyone involved, right? If I just looked at his lower back and thought it was a lower musculoskeletal issue, I would have treated him, and it would have been a disaster right there in the office because the bones were brittle, right? It metastasized into the bone. The integrity was very, very weak. So other diagnostic tests, there are radiographic tests, there's ultrasound, magnetic resonance imaging, the MRI, CAT scan, CT, and then of course there's always biopsy, which takes a sample of the cell or the tissue. The histological and the cytological exam is designed to determine the degree of the differentiation and the tumor type. And they may be tested for growth promoter sensitivities, such as estrogen-dependent tumors, like certain forms of breast cancer. And it's the most dependable confirmation of malignancy, okay? Having these biopsies are the most dependable confirmation of a malignancy. Okay, so this is a good place to pause. If you'd like to pause, go over your notes, jot down a few things that were important. Otherwise, we will move on. We're going to move on to the spread of malignant tumors. So the primary tumor is the parent tumor. The secondary tumor is the identical cells of the primary tumor, but it's in a different location. So the mechanism of spread is what we called invasion. Now, there's local spread, where the tumor cells contain these lytic enzymes. And you've heard me use the word lytic or lysis in other lectures. And lysis, when something is lytic, it's going to break down the tissue. So the local spread is now going to invade and spread into the adjacent tissue that it's next to, and it's going to destroy those normal cells. So a good example of that is uterine carcinoma. Carcinoma tells us it's malignant compared to just oma. And the carcinoma tells us that it is of the epithelium, and it's invading the vaginal canal. So here on the top, if we look at some of the anatomy here, so this is the vaginal canal. Right when the vaginal canal moves up, the invagination here and here, remember that from anatomy and physiology, that is the fornix, and here is the tip of the uterus, which is called the cervix. This is the uterus. This is the uterine cavity. Remember, there's the endometrium, myometrium, the perimetrium. So this is the uterus, and here's the tip of the uterus called the cervix. So there is some sort of carcinoma in situ, right? It's right here. It's non-invasive. You could see you have the basement membrane. The tumor cells are in situ here, right? Here are the normal shape and size of the cells. Now we have the cervix that's starting to be a little bit invasive, and we can see here it's starting to break through, right? It's starting to break through the basement membrane, and it's just being invasive here. Then we see that it's extremely invasive, and now you can see that it's multiplied and divided, and it becomes just widespread. So here is the pubic bone. Here is the urinary bladder, right? And then here's the urethra. So this is where urine comes out. And then here is the uterus. This is where baby would come out. And then here is the colon. Here's where bowel comes out. This is from a lateral or a sagittal view from anterior to posterior. And you could see that the invasiveness, probably from the lysis and all the enzymes, started to erode and spread through everything here. And that's what metastasis is, right? That's the mechanism of spread, is metastasis. It can spread to distant sites by blood or lymph or other body fluids. The liver and the lungs are really common sites due to the amount of blood supply and lymphatic flow that they have. An example of metastasis would be carcinoma of the colon, and it spreads to the liver. Okay. So here we have a primary tumor, and we can see that part of this is now in the lymphatic vessels. We can see part of it here. We see part of it in the vein. Here is a lymph node. This would be a lymph duct. Remember, all of the lymphatic vessels eventually drain into either the left subclavian vein or the right subclavian vein, right? So now you're going to see the tumor cell lodges in the capillary bed. We can see it here. And then the secondary tumor can grow and spread, right? It's going through the blood vessels. And now looks like we have some spreading into the lungs. Look, the lungs are highly vascular, right? They have to be because they're picking up oxygen. If we look here, off to the right, it looks like we have a breast tumor or a breast cyst here. And the breasts are highly, not just vascular, but also lots of lymph nodes through there. Even in the axilla and the armpit, there's lots of lymph nodes. In the entire upper arm, lots of lymph nodes. So it can spread to the axillary lymph nodes. And then it's going to follow the lymphatics into the vena cava. Okay. And then it can eventually spread into the lung, right? So, it's pumping everywhere that it's vascular, and the lungs are highly vascular. Then after it goes to the lungs, then it's going to be pumped back into the heart, right into the left ventricle, where the left ventricle is going to push the blood up into the arch of the aorta. So the aorta can carry the tumor cells from the lungs to just about every organ, whether it's going to go up into the brain or it's going to push it down to the abdominal aorta, into the reproductive organs. It's really unfortunate, but this is how it can spread. It can spread into the liver. Just remember back to anatomy and physiology, right? From the left ventricle, you have that aorta, and then the arch of the aorta goes up and feeds the brain. It feeds the arms. Then it comes down into the thoracic aorta, the abdominal aorta, and the abdominal aorta has all of these little extensions. Some of it goes to the liver, some goes into the stomach, some goes into the kidneys, then it goes into the ovaries or the testicles. So it can hit just about any organ. Seeding is the spread of cancer in the body fluids or along membranes, and it commonly occurs in the body cavities. An example of that would be ovarian cancer. The body cavities, you remember, like the pleural cavity, the peritoneum. So here is the peritoneum. We can see that a lot of the abdominal organs, like the intestines, the uterus, the liver, they're engulfed and surrounded by the peritoneum. So some tumors can spread through the membrane. So here is the primary ovarian tumor, and you could see the peritoneal membrane is just continuous with everything, so it can kind of spread into the liver, or it could spread from the colon into the liver, or ovary into the colon. It can really travel to any of these secondary organs. Throughout the peritoneum, there's the peritoneal cavity, right? And in this cavity is just, it's all fluid. Now, cancer can be staged, and it's essential to stage it so they know how to treat it, then they know what the prognosis is. And the way they stage it, there is a common system called the TMN system. The TMN, the T is for the size of the primary tumor, that's the T. The involvement of the regional lymph nodes, that's the N. And then the spread or metastasis of the tumor, M. And then there's a grading of the T, the N, and the M. And I'm not going to ask you to know how to grade them, but I think it is important that when you see someone is a T1 or an N0 or N1 or an M0 or M2, that you know what the T for tumor, the N for nodes, and the M for the stage of metastasis. Carcinogenesis is the process whereby normal cells are transformed into cancer cells. And the process of this is going to vary greatly in respect to time. And it's multifactorial because of environmental effects, because of genetic expression. There are genes that can repair DNA, right? DNA can be damaged, and your body has mechanisms to detect that and to repair it. I think of them as the housekeeping genes. And then there are genes that cannot be repaired, and then they're damaged, and then there's problems. Or there's genes that program for cell death, right? There's genes that program for reproduction and multiplication, and then there's a certain time where cellular death is programmed. That's what we call apoptosis. And then there are oncogenes. Oncogenes are cancer-causing genes, and they can get turned on. What turns them on? These are multifactorial. It could be physical stress, emotional stress, chemical stress, toxins, endotoxins, exotoxins. Could be so many different things. What else? Tumor suppressor genes, right? We have genes that can suppress tumors, but if they get turned off, then we have a problem. And then there's infections in some cases, like cervical cancer can come from the human papillomavirus, and hepatic cancers can come from hepatitis B or hepatitis C. So a combination of factors or repeated exposure to a single risk factor leads to changes that can activate or change gene expression. Normal cells convert into a malignant cell. And some cancers have well-established risk factors. They used to say years ago, when I was a kid, used to say smoking may cause cancer. May cause cancer. Now they say smoking causes cancer and lung cancer. So things have changed quite a bit. There are initiating factors. Initiating factors are also referred to as pro-carcinogens. They cause the first irreversible change in the cellular DNA. They do not create an active neoplasm, though. Then there's exposure to promoters. These are going to cause further change to the DNA. The cells become less differentiated. The dysplasia or the anaplasia becomes much more evident. The mitotic rate, the cellular division, is going to increase. The tumor and the tumor size will increase and develop. And some of the promoters can include hormones and environmental chemicals. The stages of carcinogenesis, continued exposure and DNA changes are going to result in malignant tumor growth and the invasion of local tissue. And the changes in the regulation of growth is going to result in the metastasis. And there's going to be a picture that comes up here so we can go through what's happening here. In this column here on the left, we're looking at all the different carcinogens. Radiation, excessive radiation from the sun, the viruses, cigarette smoke, hormones, food additives, industrial factors. So these are the carcinogens. And then right in the center, we can see the process that eventually leads up to cancer. And then on the right-hand side, we're looking at the cellular changes. So you have, your genes here, and there could be irreversible mutation of the DNA, especially when you have, excessive UV light or radiation that hits it. And on top of that, now we can have these additional promoters where you can have viruses, you can have cigarette smoke. So now you get this repeated exposure to carcinogens. That's the additional risk. And then we have more promoters, right? Food additives and industrial breathing and exhaust and car fumes and things of that nature. Just additional changes to the DNA and the cell structure, and eventually you'll end up with cancer. And here you start with the normal cell, right? Good nucleus, good cellular membrane, but then eventually we can end up having a cell that starts off, and then we start to get this proliferation from one cell. They can proliferate, and then we start to see that there are some membranous changes that take place, and maybe your immune system catches it. Maybe the immune system surveillance will catch it, and maybe it'll destroy it. Or it doesn't, and then it continues to divide and multiply and become malignant. There are some genetic factors, oncogenes. These are going to regulate, oncogenes that regulate all growth. Okay, so an example of that would be BRCA gene. Okay, BRCA gene is a breast cancer gene. It doesn't mean that the person will for sure get breast cancer. It just means that if the person isn't careful and they don't eat well, and they don't think well, and they don't move well, and they have exotoxins and endotoxins, and they drink and they smoke and they get excessive radiation, eventually the oncogene is going to express itself, and then the person will develop breast cancer. There are also oncogenes for leukemia, retinoblastomas, for many types of cancer. There are viruses. There are oncoviruses that can alter the host cell DNA. An example of that would be cervical cancer from HPV, or hepatic cancer, liver cancer from hepatitis C. And there's Kaposi sarcoma. There's the word sarcoma that is associated with HIV. What else? What are some of the other risk factors? Radiation, UV rays, X-rays, gamma rays, radioactive isotopes. The risk is increased, obviously, with higher cumulative dosages, and they can result in skin cancer or even leukemia. What are some of the chemicals that people could be exposed to that are carcinogenic and cancer causing? There are many organic solvents. People have been exposed to asbestos. Um, there are people who graduate with masters in environmental sciences, and they'll work for these environmental companies that will go out into old buildings and old schools, and they will um, detect asbestos and remove it. I remember when I was 18 years old in the summer, I would work 2 or 3 different summer jobs. And one of them was in my local school district. And when the schools were closed, I would go in there and we would wax the floors and just do some maintenance stuff. And it was a really, really good summer job. And I thought for an 18-year-old kid, I was being paid pretty darn good for it. And then I saw these other guys that were coming out of these holes in the ground, deep in the ground. They come out, they're not wearing shirts, they're sweating, they have rags on their forehead and all torn up jeans. And this is probably in the probably early 90s, late 1980s, early 90s. And I said, what are those guys doing? What are they doing? And they said, they're making $100 an hour. And I said, $100 an hour? I said, I would love to do that. Can I work for them? And I remember the head custodian said, you don't want to do that. And I said, why? And he goes, they've detected asbestos and they're removing it. And I said, what's asbestos? And they said, dangerous stuff. You got to stay away from it. And I said, these guys aren't even wearing protection. I mean, and it was allowed back then. So now they have these, hazmat suits, and they have to wear all this special gear. You can't breathe that stuff into the lungs. It's, I would highly doubt that any of those people are alive today. No chance. So heavy metals are also carcinogenic, and they're also damaging to the neural system, not just cancer causing, but toxic to the neurology. We've had many patients over the years that are on the spectrum, and we've tested them for metals, and many of them flag very, very high in mercury or aluminum, and it's damaging. And then you have to look at, well, where are the sources of these things? Why is there aluminum high? Why is there nickel high? Why is the mercury levels extremely high? Where are the sources in the environment that these could be coming from? They know that these metals are dangerous because they'll tell a woman when she's pregnant, stay away from eating too much tuna fish because of the mercury. Have to be extremely careful of the sources of mercury. I had a cousin who was a dentist for about 40 years, and they used to put mercury in fillings. The silver fillings were mercury. And I remember I said to him, you guys are using mercury in teeth. And don't you think that's dangerous? And he just said, everyone's got to die of something. That was his answer. Now we know that it's very dangerous, and if people do have dementia or Alzheimer's, the first thing I do is I tell my patients, even when I do my exam and I look in the oral cavity, and I say, you got to get those removed. There are special dentists that are trained to do that because you can't just drill them out. You'll have mercury going through your circulation. It'll be very, very damaging. So all of the dental staff has to be protected when they remove mercury from the mouth. It's pretty serious stuff. Formaldehyde. Years ago when I did human dissection, as a student, I remember for about a good year to a year and a half, we're dissecting the brain and the spinal cord and the heart and the lungs and all these tissues, but we would, the rooms and all of our clothes would stink because they embalmed the cadavers with formaldehyde to preserve it. And I would just leave each of these classes exhausted just from breathing that for a few hours a day. Um, Chemotherapy agents are risk factors, and all of these things, asbestos, metals, they can cause lung cancer, leukemia, bladder cancer. They don't choose. They really don't choose. Can't really predict it all the time. Biological factors. Um, Chronic irritation and inflammation can cause it. An example could be colon cancer from a person that has ulcerative colitis. Oral cancer from the constant irritation of smoke. Leukoplakia as well. It just creates like this white coating in the mouth. Age, cancer is more prevalent in older adults. Diet also, in terms of colon cancer, it's higher with people who have diets high in traditional saturated fats. Not all saturated fats are bad. Trans fats, very, very bad. But also we want to make sure that a person consumes somewhere between 35 and 40 grams of fiber each day to eliminate the chances of colon cancer. Gastric cancer is also high when consuming smoked foods. Certain people can handle them. There are certain cultures that can handle smoked foods, but not everyone can. And then there are hormones that are risk factors. Endometrial cancer with estrogen, for example. You want to be able to limit the exposure from sun or even tanning booths to decrease the risks. Making sure that there's routine and regular medical visits and dental visits for the proper screenings. Self-examination also reduces the risk for cancer. And diet certainly has a major impact. Increasing the fiber content, reducing the fried foods and trans fatty acids. But you have to be careful when it says reduced fats, because olive oil is a good fat, and coconuts, coconut oil is very healthy, and consuming avocado is a good fat, and the fats that come from nuts also very good. So when I see reduced fats, you have to really look at that and go, well, what are they talking about here? Making sure that the person consumes the rainbow diet. Okay, the rainbow diet are foods that are, Roy G. Biv, red, orange, yellow, green, blue, indigo, violet. They're all loaded with phytonutrients. Each color has different vitamins and different minerals and different health benefits from it. And they tend to be loaded with antioxidants. Reactive oxygen species are very damaging to our DNA, and if you can consume antioxidants, then you just reduce the changes in DNA. There are some really strong and powerful antioxidants that people really should be eating foods high in it, and if not, supplementing it. Supplements are called supplements and not substitutes, right? Food is always best, but you can't always get everything from the diet. And that's where vitamin E comes into play, and vitamin A comes into play, and vitamin C, which has powerful antioxidant capabilities because it helps to recycle glutathione. Probably one of the most important antioxidants to humans is glutathione, and we can produce it ourselves. And that is assuming you have good, complete proteins in your diet and you have good stomach acids to break down those proteins into amino acids. And then your body can take three very important amino acids: glutamine, glycine, and cysteine. And when you take glutamine, glycine, and cysteine, your body takes those three and it can produce glutathione. And I think of glutathione as like a bulletproof vest, and it's taking these hits, it's taking these bullets, and the bullets are the oxidants or the reactive oxygen species that are, inside the body that are going to damage DNA, and the glutathione traps them and keeps your body safe. And then vitamin C is really important to recycle that glutathione. So really, really important to make sure that the antioxidant systems in the body are working, and not just glutathione, but the cells also have them. Um, the cytoplasm of the cell has copper and it has zinc, and it has copper zinc superoxide dismutase, which is an antioxidant system that protects the cytoplasm and the organelles. And then the mitochondria has its own, which is called manganese superoxide dismutase, to protect the mitochondria and its cell membrane. So, the innate intelligence of the body is really quite amazing in its protective mechanisms. There's cell-mediated immunity that recognizes some of the tumor cells, and then these T cells do have the capability of destroying them. And then there's also some immunizations that have been documented to be helpful for cervical cancer and for hepatitis. So they recommend them to reduce the risk of some infections. In terms of treatment, depending on the specific type of cancer, there's surgery, chemotherapy, immunotherapy, radiation, and sometimes a combination of all of them. So if we look at this graph here, you've got going vertically the number of the malignant cells, and horizontally left to right, we're looking at the time factor here. So here, if we start from the lower left, and you look at the small little red dot, that would be the tumor size, right, and the growth. And you can see as you start moving obliquely upward, you can see that it's getting a little bit larger. And at number 2, we see that maybe the signs appear, and the person goes to the physician, and it's detected and it's diagnosed. And if it's diagnosed early and they do early surgery and they can remove it and eliminate it, then there could be a very fast cure. Okay. Or perhaps they do a diagnosis, they do a little early surgery, and then it doesn't really go straight down as a cure. Maybe they need some additional therapy, so they do a little radiation or chemotherapy, and then in a little bit of more time, then it's cured. Okay? Or some more time goes by, it's not treated early, maybe it's resistant to treatment, or the treatment is just delivered at a later time. Maybe some time has passed, then they do the late treatment, or they do radiation and they do chemotherapy, but a much later time. You see, it doesn't just drop quickly. It takes a little bit of a longer time for it to get to a resolution. Okay? And maybe somewhere along here, it can start to spike up a little bit in certain individuals. Or treatment doesn't work. Nothing is going to work. And then they're either just move into this, hopefully with some dignity, and they transition and they die, or they can just do some palliative treatment to try and get the person comfortable towards the last stage of their life. In terms of surgery, they can remove the tumor and all of the surrounding tissue, and that could be done with a laparoscope and several, very small incisions. The smaller the better, so it minimizes scar tissue and damaging the adjacent tissue. And also, the smaller the incision, the chances of the recovery time is going to take a whole lot less. The removal of the adequate surrounding tissue, if they're removing large tissue cells and a lot of soft tissue and connective tissue, then you will see a change in the function. Because if you're removing a lot of structure, then you're going to remove a lot of function. Radiofrequency ablation, RFA, that's an alternative surgery. For small single tumors in the lung or the liver, it's less invasive, and it's tolerated pretty good by the patient. Radiation therapy, sometimes radiation therapy is used alone, or it's combined with other therapies. It causes mutations or alterations in the targeted DNA, so it's going to stop the spread or stop the reproduction and mitosis, and it causes the death to the cancer cells. It can cut off the blood supply to the tumor, and it's most effective in the most rapidly dividing cells. Some types of cancers are just radio resistant. Okay. And it also may be used as an adjuvant therapy prior to surgery or to shrink the tumor. That's all still radiation therapy. The radiation therapy can be administered by an external source, which is a cobalt machine. It's just radiation for a short period of time aimed at a very specific site in the body, and it could require multiple treatments to that one area. Then there's an internal insertion of a radioactive material at the tumor site, and that's designed to treat specific type of cancers like cervical or oral tumors. They can also instill a radioisotope in a solution in a body cavity, and they can just trace it and follow it throughout the body and monitor to be sure that there's no leakage of that radioisotope in the area that it's moving to. What are some of the adverse effects of radiation? It can lead to depression of the bone marrow, which will result in decreased leukocytes. And if you have decreased white blood cells, then there's increased risk of infection. Results in decreased erythrocytes, the red blood cells, which results in fatigue and tissue breakdown. And it could also result in decreased platelets, which will result in decreased clotting time, so then you have excessive bleeding. There could be epithelial cell damage, damage to the blood vessels, epithelium, the skin epithelium, hair loss epithelium. Hair loss is referred to as alopecia. Infertility, that's going to end up causing a lot of, can be caused by abdominal radiation, right? Shooting the X-ray or the radiation constantly towards the abdominal region can lead to damage to the testes or damage to the ovaries or damage to the uterus. And it can lead to nonspecific fatigue, and that will eventually lead to mental depression. Chemotherapy, there are these anti-neoplastic drugs, and they can be used alone or a combination with surgery and radiation. And it's usually a combination of 2 or 4 drugs. They're given at these periodic intervals. The classification includes the antimitotics, the antimetabolites, the alkylating agents, and the antibiotics. Now, these drugs can interfere with protein synthesis or the DNA replication. So we have to look at this cycle of mitosis. Remember from anatomy and physiology, where there's the G1 or the cell growth phase, and then there's the S synthesis for the DNA replication, and then there's the G2 cell growth, and then you have mitosis, and it just keeps kind of moving around. So you don't have to, I'm not going to ask you about these drugs, but just to be familiar that um, chemotherapy, depending on which of these drugs are used, they're targeting either the uh, protein synthesis that you can see here, or they're targeting the mitosis, which is here, or they're targeting the DNA replication here. So you can see that these drugs are moving and affecting different phases of the different stages of cellular mitosis. The adverse effects of chemotherapy, so the bone marrow depression that we spoke about, it's a limiting factor with chemotherapy. So blood tests can be taken before each treatment, and they're looking for the nadir, which is the point of the lowest cell count. Um, they're going to look for neutropenia, right, decreased neutrophils, or they're going to be looking for leukopenia, decreased white blood cells. Um, Another adverse effect is going to be nausea, and that may occur prior to the treatment, right? Like anxiety and nervousness, especially if they've had it before, during the treatment, or even shortly after. And they do have these anti-emetic drugs to try and help them with the nausea. And some of the thought or thinking towards why they get this nausea and vomiting is that a lot of these medications tend to have an effect on the vomiting center, which is in the medulla region. And adverse effects of chemo continued. The epithelial cell damage. Epithelial cells can be damaged pretty easily, um, which will result in hair loss. That's alopecia. It can also break down the skin, the mucosa, so there's often signs in the mouth and the tongue, or around the lips. There's going to be damage to other areas with some of the anti-neoplastic drugs. They can get fibrosis in the lungs. It can damage the heart cells, the myocardial cells, and even damage the kidney cells. Other drugs, hormones, sex hormones, they can be beneficial when tumor growth is dependent on the hormone. So an example of that would be estrogen may slow the growth of prostate cancer. There are hormone blocking agents. They act to block the receptors for growth promoters on the cancer cells, right? Breast cancer grows when estrogen is present, so they can use a drug called tamoxifen, prescribed for patients with estrogen-dependent breast cancer, and it just blocks it. Other drugs, there are drugs called biological response modifiers, BRMs, and they just augment the natural immune response. One of the examples is interferon. They don't like to use that too much because there are very many side effects to it. There are these angiogenesis inhibitors, which will inhibit the stimulus for growth of blood vessels so that the tumors are not fed. And then there are always analgesics, and those are designed to, they're prescribed just to alleviate the pain, to get cancer patients much more comfortable. And they could be used in high dosages if needed. Nutrition, patients with advanced cancers are often malnourished. Some of the contributing factors to the malnourishment is just change in taste, right? If you can't taste things, you don't have any cravings. Anorexia, vomiting, and or diarrhea from the treatments, sores that people have around the mouth and the lips and the tongue and the gums, the loss of teeth from the radiation, pain, fatigue, and malabsorption caused by the inflammation from the GI tract. Now, besides the medical treatments, there are also complementary therapies. Some people used to call these alternatives, but we don't think of them as alternatives anymore. It's not like nutrition is not an alternative, right? It's not alternative medicine. What is the alternative to food, right? It's like saying water is an alternative therapy. Well, what's an alternative to water? So they're typically referred to as complementary therapies. Um, so massage brings a lot of comfort to people. It's very relaxing. You have human touch. It can stimulate the parasympathetics, which is very calming and very relaxing. Chiropractic, very important to keep balance to the sympathetic and parasympathetic, making sure that structure of the spinal column so that the appropriate afferent signals get to the brain in a nice, symmetrical, balanced way, and that the efferent signals get out to all the cells and tissues in a nice, balanced tone. Also make sure that all of the systems are working in balance. Remember, the neural system is the first system that develops embryologically. So, the first thing that forms is the brain and the spinal cord, and then you have these 24 freely movable vertebrae that protect them. And when those vertebrae slightly shift or deviate, they can interfere with the transmission of these neurological messages. And those messages go out to every cell and tissue of the body. So if those vertebrae are subluxated or misaligned and it's creating neurological interference, wherever that nerve goes to is going to be compromised. We remember learning that the weight of a quarter on a spinal nerve for just 3 minutes of time starts to alter the shape of cells. And when the structure of cells becomes distorted, then the function becomes distorted. And remember, cells make tissues, tissues make organs, organs make systems, and the systems make organisms. So also when joints are not moving well, not just the 24 freely movable bones, but you're looking at shoulders and hips and feet for locomotion. Whenever a joint isn't moving well, then the afferent messages going up to the central nervous system become distorted. And if the afferent messages are distorted, the efferent or motor output to the organs and tissues and muscles, they too become distorted, and there's another degree of imbalance. So chiropractic plays a integral part of the healthcare team, not just neck pain and back pain, but balancing out the neural system to optimize human health and function. Meditation, extremely important to be calm with one's thoughts, to make sure that all of their thoughts are in balance and that they're happy and that they're healthy, and that there's no thoughts that enter their mind during meditation that are unhealthy. Counseling is extremely, extremely important. Sometimes people just don't have the right tools, and certified social workers and psychologists do an incredible job at helping give cancer patients the right tools. Exercise, there really isn't any disease or state of disease that can be improved to a degree by human movement. Now, exercise in the right amount and the right type of exercise is extremely important. You have to remember that exercise means that the body needs more energy and that the mitochondria are working harder. And if the mitochondria are working harder to produce ATP, then they're giving off lots of oxidative byproducts. Remember, the Krebs cycle is also called oxidative phosphorylation. So the oxidative part needs to be offset with antioxidants. So you want to make sure that the patients have good, colorful food in their diet, fruits and vegetables, but that they also have vitamin E and vitamin D and vitamin C and glutathione and all of these things that can offset the oxidative stress. Therapeutic touch. I mentioned that a little bit with massage and chiropractic. Just simply, human contact is so important, especially in today's day of age. Research-based evidence has not been published for raw food macrobiotic diet. Um, there's a lot of assumptions that um, having raw food is much healthier. And I would say that consuming foods that are less processed, that has less food coloring and less chemicals, is always just a better decision. Um, Also, the use of insulin and glucose with chemotherapy hasn't really been researched very heavily. And healthcare workers need to be aware of all these different types of therapies to advise patients. Sadly, too many healthcare providers just say, sorry, there's nothing else that we can do. And maybe they're not lying, right? I mean, maybe there's nothing else that they can do, but there's always something else that can be done. It's just a matter of um, being involved with integrative care and collaborative care and having a network of all of these different types of healthcare providers. That's really important, right? We're trying to look out for a patient's well-being. And I always tell my patients, if I can't help you, I can promise you that I can find someone else that can. And it always brings ease to them knowing that they're under good care, that I'm looking out for their best interest. And I have patients today that still refer people to me 25 years later, not because my treatment was magical for them and that they healed, but I did not treat them. They came in, I examined them, I was able to detect and pick something else up that no one else did. I made the proper referral, and because of my good diagnostic skills, they're alive. And all these years later, they send me these, we call them the impossibles, the impossible cases or the complicated cases. And I'm not saying this to impress you by any means. I'm just saying this to impress upon you the importance of being knowledgeable, being experienced, and having good diagnostic skills and good intuition. All play a very important part of being a good healthcare provider. All right, in terms of being cancer-free, a cancer-free state is generally defined as a 5-year survival without a reoccurrence. And some cancers, such as childhood leukemia, can be considered cured after 10 years of a cancer-free period. A person is considered to be in remission when there's no clinical signs of cancer. And a patient can experience several remissions in their life. Life expectancy and death rates they vary for different types of cancer. If we look at skin cancers, they're very manageable. Most are very treatable if you catch them in their very, very early stages, compared to pancreatic cancers that could be extremely painful and maybe 6 months to a year um, for that. In terms of cancer incidence, I think it's important to know this. What are the most common cancers in men and what are the most common cancers in women? So the most common cancers in men are prostate cancer, in women, breast cancer. And then second place to third place are the same for men and women. For men and women, lung cancer, and then colorectal cancer.